Good evening, everyone. We're going to get started. I trust that you had a wonderful day and you're excited about the program this evening. We are excited because we're going to talk about a topic that's very dear to my heart and hopefully also will be to yours. So thank you for joining us here at Feet4Life Online Diabetes Resource Center. I want to welcome everyone here, especially those persons who are here for the first time. And we have some of our speakers who are here also for the first time. So we want to say a special welcome to them as well. Tonight, as always, we have an exciting program for you. And we see that persons are coming on a little slowly tonight. I heard one of our guests said, sometimes you have to be here very early to get on. So hopefully the rest of them will join us. We know persons are busy. This is a busy time. And so we're hoping that they're going to join us and be a part of this discussion. So we want to invite persons to mute your mics for us while the speakers are going. You can feel free to put your questions or your comments in the chat. And then we will also give you an opportunity at the end of the program to ask your questions or to chime in and give your comments. We are live streaming as well on Facebook, as well as recording for our YouTube channel. You can go to our YouTube channel, Feet4Life 242, to watch this video and any of the previous videos that we've had. And so we invite you to do that. We also want you to go and subscribe, like the channel, and turn on your notifications as well so that you would get all the videos as they go up. So we're going to get started, and like we usually do, we will begin with a short prayer and devotion by Elder Ian Green. He is an elder in the Seventh-day Adventist Church, and he is also the president of Adventist Service and Layman Industries for the Adventist Church as well. So he is no stranger to us because he has been here a couple of times already, and we really appreciate him coming. Taking a break from his walk to come here tonight. So we're going to invite Elder Green to unmute and give us our devotional thought at this time.
Good night, everyone. I'm praying your strength in the Lord, that everybody is feeling good and had a wonderful day. Can you hear me out there?
Yes, we can hear you clearly.
Okay, excellent. Let's just take a quick prayer before I go into the devotion. Most kind, loving, and gracious Heavenly Father, we come here tonight just giving you thanks because you have given us life. Without you, we would not be. And today, we just want to pause as we take it down a notch and recognize who you are. We want to take a deep breath in and exhale slowly and just say, praise the Lord. We ask and we invite the presence of your Holy Spirit once again to give us knowledge, wisdom, and understanding. In Jesus' name I pray. Amen. Now, tonight, our charge is taken from the book of Proverbs, and Proverbs is one of the books that I love to actually read, and I listen to Proverbs every day. I don't miss a day. It's like walking for me. You can't walk every day, and then some days you don't walk. So Proverbs is one of my favorite books in the Bible, and Proverbs 4:26 and 27, it gives us an insight into something the Lord asks us to do. And sometimes we don't think about it, It says, ponder the path of thy feet, and let all thy ways be established. Turn not to the right, nor to the left. Remove thy foot from evil. Now, God is so gracious, and he's so kind and loving. He actually tells us, there was a little song that we used to like to sing when we were younger. Somehow we don't sing it much anymore. It says, oh, be careful, little eyes, little hands, little hair. But also it says, be careful, little feet, where you go. And sometimes we forget that there's a Father up above looking down in tender love. Oh, be careful, little feet, where you go. Our feet ought to carry us to God's mission. We ought to be on God's journey. We ought to use our feet to do good and not evil. It says, don't turn to the left, don't turn to the right, but remove your feet from doing evil. We have to purposely declare and do what God has asked us to do. Listen here, it says, give careful thought to the paths of your feet and be steadfast in all your ways. This particular verse is basically saying you have to be very, very mindful of what you're doing. You have to be mindful about where you're going. You have to be mindful. Your thoughts become your action. And so sometimes somebody say, well, I was just walking and I end up in the woods. You weren't paying attention. You weren't being careful. And if you know all the animals in the woods and it's getting close to sunset, why would you go in the woods and then you can't even remember how to find your way back out? Sometimes we do things, we go places without thinking about it. The Bible is clear. It says, be careful, little feet, where you go. It says you must be mindful of what you're doing. God gives strength to the feet to stand secure and overcome all obstacles. We must know that we have a God who will give us strength to stand. If we stand firm and we believe in what God is asking us to do, and we do these simple little things, guess what? We will have our feet will be taking us to great places. We will stand before kings. We will carry the gospel to the ends of the world. We will be helping people in our neighborhood, people around the country. This is because our mindset will be things that are right and pure and holy. And wherever our mindset is, our feet definitely will go. God bless you. Have a good evening. And I'm praying for all the presenters tonight. Blessings to all.
Thank you so much, Elder Green. Always a pleasure. Thank you so much. You always have a nice take on everything. So I appreciate that. I'll definitely be looking up that text one more time. It was Proverbs 4 and what?
26 and 27.
All right. Thank you so much. I will definitely be looking that one up.
You're welcome.
All right. So thank you for our devotion. And now we're going to move on to the rest of our program. Everybody who has been here or who are part of our channel knows that diabetes is near and dear to everything that we do. And what is our mandate? Say among diabetics, foot complications are some of the most common, most costly, and most feared. Recent research showed that persons who have diabetes and have a foot complication were more afraid of dying or of having an amputation than of dying. Let me say that again. Persons who have diabetes and have a foot complication, they were more afraid of getting an amputation as opposed to dying. So you know that's a serious, serious, serious concern. As many as 25% of persons who live with diabetes will experience some foot complication. But this channel and our work and our ministry is to help persons to keep their feet for life. And well, tonight is no different. We will not be specifically talking about the diabetic foot, but we'll be talking about the people who are charged or who are best prepared to take care of those feet. So I don't know if you know or if you heard, but yesterday, October 8th, was celebrated as International Podiatry Day. See, I got on my t-shirt and everything. But so tonight, we're going to be talking a little bit about podiatry and the role that they play in protecting and preserving the feet of persons, not only those with diabetes, but of everyone. You know, the slogan that our theme is podiatrists keep, well, not only the Bahamas, but everywhere, keep us on our feet. And because of that, we're going to learn a little bit more about what podiatrists do and how we keep persons on their feet. Just some information for you. So the International Federation of Podiatrists was formed in 1947, and it's an international body that governs and advocates for all podiatrists and the service or the profession of podiatry. So historically, archaeologists have discovered evidence of in Greek runes and Egyptian tombs that podiatrists were about from that time. And we know, of course, Abraham Lincoln and many other historical persons wrote in their journals and their memoirs about their foot doctors. So podiatry has been around for a very, very long time. On the 8th of October every year, we use that time to bring awareness to the profession. At this time tonight, we are going to have a panel discussion, not only with podiatrists here in the Bahamas, but also other podiatrists that are from our region. So I don't know if you're aware, but we have a shortage of podiatrists, not only in the Bahamas, but everywhere in the world currently. And in the Bahamas, we currently have 5 podiatrists, which is the largest amount we have ever had. And also, besides Canada and the United States, I think we have the largest number of podiatrists, I guess, in this region. So this evening, we will discuss the role of podiatrists and how we contribute to saving limbs and lives. And so we're gonna get right into that. So we have, I think, 2 of our panelists here. We'll begin with them. And when the other one comes, we will allow her to join us. So we're gonna ask our panelist, Dr. Allysa Knowles Adderley, who is a young Bahamian podiatrist who recently returned home. And she is going to be one of our panelists. And so we're going to invite her to unmute her mic. And then Dr. Adrian Mullah, who is another young podiatrist who's from Barbados, and he will also be our second panelist. Our third panelist, I will introduce her just in case she gets here in time. Dr. Marian Davis, who is a podiatrist from South Florida. She's from the Miami area, and she's actually, I guess, the veteran among this group because we actually went to school together and graduated together some time ago. So she is the veteran in the group. But as soon as she comes in, we will allow her to join. So we're going to invite Dr. Mullah and Dr. Adderley to unmute, and then we'll begin our discussion. So tonight our meeting is in the form of a panel discussion. So we don't have a presentation specifically, but we'll have a discussion. But you still can put your questions in the chat, and you can still raise your hand if you want to have a comment or you have a question. So we can ask them to join us at this time.
I'm here.
Okay, awesome. And
Good night, everyone.
Okay, good night. All right, so we're going to get started. And so we're going to ask ladies first. So Dr. Knowles Adderley, we're going to invite you, and Dr. Mullah, you can tell us after she's done. Just tell us a little bit more about yourself. Tell us about how did you get into podiatry? How did you end up here in this profession at this time?
Okay, so hi, good night, everyone. I'm Dr.
Good night.
Allysa Knowles Adderley. I was born in Nassau, Bahamas, grew up in Grand Bahama, and I've always, from a young child, just knew I wanted to be a doctor. Um, what kind of doctor? No clue, I think I hate to say back in my day, the access to that's where I'm at now. Back in my day, we didn't have like internet access to show the different fields of medicine, but I just knew, okay, doctor, and I'll figure out. I just have to figure out what's the next step. Just keep going next steps. So the first step was to get into college, and I did that, and I was getting my bachelor's of science in biology, and my anatomy and physiology professor at that time, she was a podiatrist. So that was the first time I heard the term or knew anything about it. So I asked her, I inquired a bit more, and she was quite informative. So I decided to shadow a few podiatrists and I took interest in the field. From there, once I graduated, I pursued my doctorate of podiatric medicine. So I went down, I was in Syracuse, New York, and then I moved down to Miami, Florida, and I went to Barry University and I got my doctorate of podiatric medicine. And during that time, I was interested in like the sports medicine aspect of it. And of course, residency is next. And I did my residency in Brooklyn, New York. And that's when I was just exposed to just so much. Once you're in the hospital, you're hospital based. It just opens your eyes to just so much. And um, I took on the more surgical route, and that kind of consumed me. And I stayed there for over a decade, um, just learning, teaching, and just continuing to get better at my craft. And then in 2022, I decided to do the family route, and I decided to return home to the Bahamas to, one, raise my family, and two, join the team of podiatrists here and contribute to podiatric medicine in the Bahamas. So currently I practice in New Providence, Nassau, and as well as Grand Bahama and Eleuthera. And I provide a full range of foot and ankle care.
Awesome, awesome. Thank you so much. Dr. Mullah?
Thanks for having me as well, Dr. Mitchell. And yeah, it's my first time here. I didn't even know this was going on. And it's a really great thing you guys have going on. I see lots of people joined in from all over the place. So great, great stuff you're doing. And similar to Dr. Knowles Adderley, I always wanted to do something in the medical field. I didn't really know what, to be honest with you. And I think I was when I was in university doing my chemistry and biology degree. I was playing a lot of sports, lots of basketball, and I was getting lots of submucous hematomas. So lots of bruising on my toenails. And I remember my mum dragged me to a podiatrist and she said, okay, you're going, I'm not seeing you limping, I'm not seeing you in pain anymore. Get these feet checked out. And that's my first introduction to a podiatrist. I didn't even know they existed. And from then on, the podiatrist I shadowed, she gave me, I think it was a magazine about podiatric surgery, sports medicine, different things. And after looking through that, then I said, hey, this is something I'm interested. I quite like this. So after that, a couple years later, I think, yeah, I went to Southampton in the UK. So I'm UK trained. Did my undergraduate there, then did my master's in podiatric surgery. That was up north in Huddersfield. While I was there, I also was working. So while I was doing some surgical training, also doing vascular training, which actually got me very interested as well. Because during university, I said I hate wounds. A surgical wound is fine, but diabetes wounds, I did not like diabetic foot ulcers. And yeah, I'll confess that right now. But after getting a taste for how complex it is, how much impact you can make on someone's life, I went down more the vascular route, and you're going to see diabetic foot ulcers anyways. And that really drove my passion. And I think I was about 2 years after that, I was doing some private work after coming out of the healthcare service, the NHS. And Simone, she kind of approached me and was like, hey, what do you think about coming back? We kind of need some help back here. So then I said, yeah, you know what? I'm not doing anything right now. Why don't I come back home and try to give back? So here I am. And I only returned this year in January. So I'm still fresh. I'm still getting used to things, but yeah, that's where I am now.
All right, awesome, awesome. So that we all have, I guess, a similar background. The fact that, all of us said we didn't hear about podiatrists before we actually got interested in this field. So definitely that's some work we need to do to get the word out about podiatry and how great it is and what a blessing it is to the people who receive that service. I wanted, Dr. Knowles Adderley, you did not mention that you're raising two young children under the age of 5. She's a
Under the
superwoman.
age of 3. Yes.
Under under the age of 3. Yeah, so she has her hands full, very full. All right, so our next question is going to be, what are some of what, as a young professional, both of you were young podiatrists, not too long, came back home to your countries, because Dr. Mullah is actually from Barbados and living and practicing in Barbados. What are some of the challenges or the joys that you have experienced since your time coming home, and having made that decision? Because there are others who have trained and who did not return home. And we're very, very appreciative of you coming back, like you say, to give back to this area. So tell us a little bit about your experience of coming back, and then what are some of the things that you're seeing, your experience, like what are you seeing in your clinics, the persons that you're seeing, what are you seeing?
Me first, right?
Yes.
Okay, so, well, I'll talk about the joys first. The joys is that you're home, you get to, be around the type of people that you grew up with. Now, granted, I was in Brooklyn, so it's very Caribbean there. Um, but it's one thing, treating people who have access to just a little bit more in America versus coming home and just finding ways to provide that access to patients that are from where you're from, you know? Um, but in the Bahamas, I think the biggest challenge we face is linked to diabetes, delayed care, and the lack of access to specialized treatment. We see far too many, or from I've been home, I see far too many patients with advanced diabetic foot complications um, that could have been prevented just with proper screening and early diagnosis. Um, just if they were to see a podiatrist prior to it becoming a problem. So I think the key here is that I see patients in crisis as opposed to just that preventative care. And I think that's a concept we have to like get across to the different professions, that don't wait until it's a problem that, okay, now go to her. We want to be treating patients as beforehand and avoiding complications, avoiding any issues prior to. And a lot of times what tends to happen, what I do see is that sometimes a patient may come to me complaining of some foot issue, and at this point they haven't seen a PCP in many years, and I'm the first one to diagnose them with diabetes. I order some blood work, and okay, now it's a whole, so it can go either way. Either I'm seeing them when they don't even know they're a diabetic, and now we have to take it from that standpoint, or I'm seeing them when things are a little bit too late. Or super complicated when it could have been, if we were seeing them more often, every 3 to 6 months, things that could have been avoided. I also think there's a general gap in public awareness about foot health and how it ties into just overall wellness. So people often think about wounds as maybe minor until they progress to something more serious where they're infected. Additionally, we face challenges with even just footwear. We live in a hot climate, so a lot of times just the supportive shoes. Well, one, we live on an island where things can be a little bit more pricey to even obtain more supportive footwear. But two, we live in a hot climate where people just want to wear their flip-flops and go about their day. So sometimes that can put them at risk where they're out in the yard gardening in some flip-flops, and just, they face challenges with that, or issues that can arise from that. But I think ultimately many of the issues stem from lack of early screening, and then maybe an insufficient multidisciplinary management where we work as a team from all different specialties. And also the limited availability of the podiatrists, ourselves. There's only so much of us, and we have so many different family islands here. So those in the family islands are especially, maybe not so much in Nassau because we're all here on this one island. So the family islands, they tend to not have as much access to care.
Okay, so for
Awesome.
me,
You covered a lot. Go ahead.
kind of similar. I'd say in the UK, yeah, definitely I saw people having much more preventative care. And where I worked in the NHS, you've got diabetes specialist nurse, you've got your foot care practitioners, assistants, podiatrists, and people have like every 2, 3 month, and at most probably a 6 month review. When I came back here, there's nothing like that set in place, or they may be, but it's a challenge because in the public system, we've only got, I think, 2 podiatrists working right now. And Barbados, I mean, it's not big, it's quite small, but let's say population 300,000, 2 podiatrists in the public system. You can do the math. That's going to take some time to screen and see people. So working over there, I saw a lot of preventative care coming back here. As Dr. Knowles Adderley said, a lot of people are in crisis mode, or they're at the stage where they're like, okay, I've got a hole in my foot. I can't really feel it, so I don't think it's that bad, but I think you may want to just have a look at it. By the time you look at that, then yeah, you're trying to get into action, trying to reverse a lot of the damage that's been done. Similarly in Barbados as well, foot health is a big thing that people don't really put a lot of stress and emphasis on. It's only when it gets bad, and shoes is a big deal. In a hot climate, trying to get my patients even to use an orthotic and even a trainer or a sneaker, that's like, I don't go to the gym, why am I wearing that? Most people are in sandals and flip-flops, so that posed a challenge. And even with shoes right now, they are quite costly on the island. I'd say to get a decent pair of shoes, you're looking at about 200, 300 Barbados dollars. And for the average person to get even multiple pairs of shoes, that's going to cost. So people have to rely on getting stuff overseas, and even supplies for us, we have to bring it in from overseas. So there's some
Right.
challenges there. And one thing we recently started here in Barbados, with the help of Ortho Feet and Samaritan Feet in the US, they've generously donated some shoes to us to help with the diabetic foot population. So we've been doing that, rolling out some screening in the polyclinics, the public system, screening in the hospital as well, and just starting to risk stratify everyone and see who can benefit from some shoes. And it's a donation, so it's a big deal. A lot of people, when we give them that pair of shoes, they're like, you're giving shoes to me. Like, that's really strange. Why would you give me a free pair of shoes? But then when you hear the stories, one person came back and they said, look at the nail that's in this shoe. If I didn't have this shoe, I would have had a slipper or a flip-flop, and that nail would have been in my foot. And they were peripheral neuropathy. They had like 0 to 10 sensation on their foot. So it's a big deal when just from a shoe aspect that we're seeing here in Barbados as well.
Okay, awesome. So definitely that sounds like you're doing a lot of exciting stuff. Definitely we've been doing something very similar here with the screening. We have taught like our nurses in the clinics and the different parts to do the diabetic foot screening. And like you said, there's a lot of people compared. In the Bahamas, we only have one podiatrist in our government system, and I think it's one clinic a week. So that is definitely an access problem, and most of the persons who come to see us, because all the rest of us are in private practice, so it presents a challenge to persons who don't have insurance and trying to get access to the services. You also mentioned, about the foot health and wellness, and I also wanted to agree with you because, the foot is the most neglected part of the body. And because I guess it's furthest from the head and persons don't think about it, they don't really seek care until it's really, really bad. Like you say, they have a hole in the foot or something like that. So our next, oh, I also wanted to mention too that we had done a similar thing with the diabetic shoes. We actually got, I don't remember how much it was, but we got a lot of shoes donated. And most of them are gone, but we have some shoes that the men are really, really slow in coming to get the shoes. The women, they tend to come and they come pretty quickly and pick them up. But even now, we still have shoes for men who smaller sizes, but that still are available that we really can't seem to give away. And that really was a surprising thing for us, you know. And these are very expensive diabetic shoes. Like you say, they would cost between $300 to $400 and because they're imported. You have to bring them in and everything. So definitely, and they're not covered by national insurance or NHI or anywhere like that. You would have to pay for that out of pocket the same way here in the Bahamas. So we were talking a little bit about the challenges we see in our clinical practices. What about neuropathy? I think that's one of the challenges that we see for that's a big problem for most diabetics or a lot of diabetics. They seem to have symptoms of neuropathy, and then you can talk about the link between that and going downhill to getting the other complications. And then what are you doing in your country, or what are you seeing and what are you doing there for that?
For peripheral neuropathy, specifically.
Or any of the other diabetic complications. Yes.
So basically, all diabetics that come to see me, I automatically do a screening for sure. And we test to see, and especially if they return, and I try to implement where if their A1C is above 8, I have to see you every 3 months for sure, every 2 to 3 months. If your A1C is, sometimes you have more stable diabetics. And if they're more stable, A1C closer to the 6 range, they have, they're without any complications, then we can push it to 6 months, or sometimes I even say, okay, you know what, I can see you annually. But for the most part, anything with any A1C that's uncontrolled, that's my starting point. Okay, because now you're at risk for increased chances of peripheral neuropathy, or even um, arterial disease. And I want to just make sure we're on top of things before it becomes a problem. So I just try to preach how quickly things can become a problem. I try to, because it's not hurting you doesn't mean that something is not hurting you, because you can't trust yourself to protect yourself. So I just try to get that through their head, because the first thing is that, oh, it wasn't even hurting. No, because you cannot feel it. So I try to get them to understand that concept of that you're not really, you can't protect yourself. Your feet are not protecting you the way it should be. So I need you to just use your mind and say, okay, I need to protect my feet for me. And once I guess it's more so education. I think that's the number one thing we can do is to try to educate them as best we could, because a better understanding leads to being more compliant. And in terms of treatment, you know, it depends on with neuropathy, it all depends on how advanced it is. You know, sometimes it's to the point where, you know, nerves is only so much chance you or is only so much that can be reversed. Once it's damaged to a certain extent, that's more so just protecting yourself as well as treating the symptoms, not really, you know, anything that to completely reverse it after a certain point. So I do um, try to educate them on that, as well as making sure they control, you know, the best form of treatment for it is to make sure your diabetes is under control. Because if that's not under control, nothing else, like no pill I give you, no vitamin I recommend, no shockwave therapy is going to make any improvements if you're not treating the disease itself.
Okay, Dr. Mullah.
Yeah, just to add on to that, sometimes I see people and they just say I've got lots of tingling, pins and needles, my feet feel fuzzy, they don't feel the same. And when I send them for screening, or we do the screening, and yeah, they're coming back as neuropathic. When we do the bloods, we're seeing A1Cs, which are like 10, 11. I even saw someone with a 20 A1C. And I was like, okay, how long has this been like that? And they're like, I'm not really sure. I just went to get it for the first time. So I think getting it into the minds of everyone that it's not something where you're just going to see it one day and it's just going to happen with a hole in your feet. Peripheral neuropathy just starts to build and build and build with that little callus. And seeing a podiatrist regularly, seeing someone to even check the bottom of your feet, that's important. And some people, when they come to me, they're saying, okay, well, I'm not really seeing the connection between it being nerve damage. Can you send me for like a nerve conduction study? Some people have sent for a nerve conduction study and they say, well, they just said it's damage to the nerves. So now what? And really hitting home protection with peripheral neuropathy. That's one of the biggest things that I've been trying to do. In terms of blood sugars as well, a lot of advice. We've been working with dietitian as well. So diet is a massive thing here in Barbados. I think a lot of the NCDs on the island are due to diet and lifestyle. And getting people to realize that it's not only just eating healthy for like a week or so, it's little consistent choices that's going to add up. And what you don't, as Dr. Knowles Adderley said, even if it's not hurting you, it could still be hurting you. You just don't know it. So you can't always trust that your body is always going to show you just one day, oh, I ate bad and it's going to affect my foot like this. It's over time. So yeah, that's a big challenge with peripheral neuropathy, but the screening is definitely helping with that.
Awesome. So we also have, I think I saw Dr. Horsley. I know he's a big advocate for screening, not only in the health center, but also for persons to do their screening at home, because a lot of times, when you do the screening and you do especially the monofilament test, and you have the patient maybe and a relative there, and you're checking all the spots on the foot, and they're not feeling any of them, it becomes a problem, because they realize that this is a problem when they realize that their parent or their loved ones don't feel any of them, and they should feel 10 spots on the feet, but they don't feel any of them. And so it alerts them to the fact that there's a problem with the sensation or the feeling. And then it's also to engage them in being a part of the solution. If you don't feel for yourself, like Dr. Knowles said, you have to use your eyes and your brain to know that you have to look at your feet every day, because you no longer have the pain sensations that will alert you to a problem. So you have to look, and then we engage our family and friends, loved ones to help help the patients as well. If they can't feel it, then the family member can actually be an advocate and help them to look and be, their ears and their eyes as well. So I want to invite persons who are on the call to tell us in the chat where they're joining us from. I neglected to say that earlier. So you can tell us on where you're joining us from so that we know exactly where you're coming from or where you're joining. My other question is, and I noticed in my practice as well, that we are seeing a lot of persons with charcoal foot. And that complication is common because if you have uncontrolled diabetes, you will tend to have that complication. So tell us a little bit more about what is going on with that in your country as well. How are you treating it? Are you seeing it a lot? What exactly is going on? You can also tell a little bit about what charcoal foot is and exactly what persons should be looking out for, because that is a common complication and a lot of persons don't, I've been seeing it in younger persons even. So yeah, so tell us a little bit more about that.
Yeah, so I actually can't even count now how many charcoal patients I've seen since I came home, and it's unfortunate. But I think one that stands out is like a 30-year-old, and he's coming to me about, a basketball injury. He's talking sports, and he sent him for x-rays. I'm like, so you really did some damage. And I'm like, this is not adding up, but of course he came to me after he tried to treat it himself for a few months or whatever. Now it's not getting any better. And you do all the CT scans, MRIs, all of that. And I'm like, oh, this is you have I'm trying to like do the math here. And I'm like, medical problems? No, I have no medical problems. I don't take any medications for anything. And then I'm like, everything is saying Charcot to me. Like, it's, do you drink a lot of alcohol? Like, what's going on? Trying to just get a grasp of what could be causing this Charcot appearing type foot. And then it goes back to being the first person to diagnose him with diabetes, ordering the blood work, and your A1C is 12, and he's 30 years old. And now I have to, get everybody on board, primary endocrinology, nutritionist, all of this, and actually break the news to him that this is actually a very serious condition, and it requires especially him being as young as he was, is more so, in an older patient, which I've had a few older patients where they're not going to go through the whole reconstructive type of procedure, or they don't want to. And it's more so just trying to consolidate the bone, get them out of the flare up and out of that inflammatory state, get things calmed down to just allow the bone to heal in whatever position, as good a position as it's going to be, whether you put them in the cam boot or you put them in a crow walker or um, uh, cast it. Um, but for him, this is someone who was playing basketball. If you look at him, super healthy, he has the muscles, he has everything. It didn't add up. So we had to set it up where he had a reconstructive procedure, and he's actually still going through the motions of healing right now. Um, But the challenge I face is the equipment here. So doing a Charcot reconstruction here, and when you practice in America, you have so much at your disposal in terms of like reps, and everything is in a room, and you can pick and choose and refuse what equipment you're going to use. And if this is not working, okay, take it out, give me something else, and it's very easy to. But here, you importing this stuff, you you're not going to spend $20,000 on 5 different things. So that's, $120,000 just having what you need here is more so like, okay, we got to order one thing and you hope this works, So that's a challenge when you're doing like the bigger reconstructive cases here, because we don't have the company reps that's based here, and a lot of things at our disposal. So his was a lot more a challenge. I had to refer him to one of my colleagues in America where I know they had everything that he needed, and it could have been done without any complications. And he's recovering home. So yeah, it's one of those things. Charcot is a tough one. It's hard to treat. And again, the number one way of treating it is the first, get diabetes under control. Once that's under control, that you stand a better chance. But um I think Dr. Mitchell, you wanted to know like what I've noticed is a lot of them say they had an injury, and I think they're always prone to it, or it could have been something that was already brewing, and then any little slip and fall, any type of trauma could just cause the breakdown to become a little bit more aggressive. And that's what I've been noticing here, that it's usually secondary to some rolling of the ankle or a slip and fall that just kind of triggered everything to just go haywire.
Okay, awesome. So, Dr. Mullah?
For me, I've been seeing a lot of Charcot in older patients actually. I mean, when I was in the UK, I probably saw about 5 Charcots. Here, I can count on my fingers and toes, both feet, how many I've seen. And it's really sad seeing so many because it is a very life-changing diagnosis for a lot of patients. We've been seeing a lot of in older patients with wounds as well. And they've had it for such a long time when we do the x-rays and the CTs and we look at the bone stock to do arthrodesis and intramedullary fixation and all of that, it's just gonna be very difficult. So sometimes, as Dr. Knowles Adderley said, getting the diabetes under control, even looking at the vascular health. I mean, sometimes I look at an X-ray and I'm just seeing calcified vessels up and down the foot, and I'm like, okay, this adds a little bit into the mix. So it is challenging. Offloading and protecting it is really key as well. So even the walkers and the casting, a lot of people, we have to discuss with them, okay, this is something you're gonna have to use just to offload and protect this foot. You can't just wear a trainer. You can't just wear slippers, definitely. That's just gonna make it worse. And once that bone collapses, then you're in
Right.
problem. A lot of people don't even want to go for the surgeries. They're thinking they're gonna get amputation. That's a really big stigma here. Some people think once you have a foot wound and you go to an hospital or you go for a surgery, then you're gonna get an amputation. And it's trying to break down those barriers to tell people, well, some people do have the bone stock, they can have the surgery. Let's see if we can explore that to help give you a better outcome. So far, we've had about, I think, 3 Charcots which we've had to refer on. And this was to one of our colleagues in Trinidad. And he's actually orthopedic foot and ankle. And he's done some great work. One of them was external fixation. And it's come such a long way, but it's such, trying to get through to the patient that it's such a high management case. We got to see you almost weekly for those dressings. Got to look out for infection, keep the diabetes down. And he's even having challenge with, I mean, external fixation. That's not easy to live with, right? So even stuff like that, just trying to get that through that, okay, we're going to do everything we can to save this foot, to save this limb, keep your quality of life, but it is a process and it does take time.
So yes, that is, I mean, it sounds like Dr. Noel sounds like I had that same patient this week. I had a 35-year-old man and he came in and he was, he thought that somebody like rolled a trolley on his foot. That's what he thought it was, that somebody rolled a trolley on his foot, and from there it happened. And the sadness for me is that he has seen, I think, maybe 8 or 10 doctors since April to now. And I was the first one to tell him that it was related to his diabetes. Most of them were telling him that he had a fracture and they didn't connect it to the diabetes. And so he was really, he went to Cuba. I think Cuba told him that, he needed to stay in the boot that he was in. But let me just take a moment to just talk about what Charcot is, because we do have some lay people on. And so Charcot is a progressive fragmentation of the bone, or the breakdown of the bone in the foot as a result of the uncontrolled diabetes. You hear both Dr. Knowles and Dr. Mullah talk about the diabetes and how important it is to keep it under control. Because when that diabetes is out of control, when that sugar is too high, that A1C, I don't think I've had a 20, I think I've had a 17, but I've never had a 20. So Dr. Mullah, you head of the class. That's the highest I've heard. But once that diabetes is out of control, then it damages so many organs in the body. And one of them is, of course, the foot, and it breaks down the bone. And you see that classic, the bone looks like it's breaking, it's crumbling. And as a result of that, the shape of the foot changes permanently. And so we need to, and a big part of it is the immobilization. You can't go to work every day on this foot. You can't be in slippers and tennis, because that's not gonna protect this foot. You're not feeling any. I told them, I usually would say, think of somebody who does not have diabetes. If they don't have diabetes and they have a broken pinky toe, the little smallest toe, if you have the broken, smallest little tiny toe on your body, that is going to stop you. You're gonna stop walking on that foot. You're gonna find some shoes that will protect it. You're gonna find a doctor. You're gonna go somewhere and get that sorted out. But most diabetics, because they're neuropathic, they have a whole fracture of the whole foot. The whole foot is broken in half almost, and they still do not feel it. And because they do not feel it, they do not stop walking on it. And even when you tell them, you can't walk on this, you need to be in a boot, you need to be off this foot, you need to be off work, they don't believe it. But I also agree with Dr. Mullah when he said that, people have that fear of amputation. When they go to Princess Margaret, most times they think if they go to Princess Margaret, they're gonna amputate their leg, but not always. Sometimes when you go and it's too late, Dr. Knowles talk about when you present late and there's nothing much you can do, and sometimes it do end in amputation. So we don't want that. There's a study done, I think maybe 2010 or 2015, that said that seeing a podiatrist for preventive care, that means before you have that ulcer, before you have that hammer toe, before you do any problem with the foot, if you see a podiatrist, then your risk of getting an amputation is much, much lower. Your risk of being admitted to a hospital is significantly lower. And so this is the reason why we do sessions like this, so persons can learn about what podiatry is, what we do, and what are our efforts, the result of our efforts are to make sure that persons are not getting those amputations. So our next question is talking about, hold on one sec, let me open my. Okay, so the next question we want to talk a little bit about is not necessarily our diabetics. So in terms of general foot health, because Dr. Mullah mentioned it, you also mentioned it, we have a lot of health conditions in our countries, like NCDs, obesity, and other issues that cause foot health to be very high of concern. We have a lot of persons who are heavy, and as a result of that, that will impact the foot and how it functions. So talk about not specifically diabetes, because we talked about the neuropathy, we talked about the sharper. What about some of the other foot conditions and things that we see in our population that as podiatrists we see every day, and how
Okay.
those are treated?
Well, what I would mention before I even get into like the classic things that we treat and we see, just to touch on like say for example, how were you talking about the diabetic neuropathy? What I have been seeing a lot of, most neuropathic patients is a result of diabetes, but what I have been seeing is a lot of diabetes, I mean a lot of neuropathy associated with alcoholism. And that is something that I guess, as a culture, it's a lot of drinking and here. And it's just surprising to me to see, otherwise healthy, patients, but just due to alcohol abuse, they have neuropathic symptoms. So that's something to take note and, to encourage people to monitor just their alcohol intake because the abuse is crazy. But the classic things we see are, your plantar fasciitis, your heel pain, and I think a lot of that is due to not being supportive shoes. And again, due to the climate that we're in. Um, Another thing is, your spurs, your retrocalcaneal spurs. Um, uh, then you can go on to the trauma, metatarsal fractures, neuromas. Um, I see it all. We see it all here. Everything it's pretty standard. I see a wide range of all foot concerns. Um, pretty broad, pretty broad. I don't really have anything in particular that stands out outside of the alcoholism one, the alcoholic neuropathy. That was super that stood out to me when I first moved back.
How do people I wonder about that myself. And you ask persons like, well, how much do you drink? How is that question usually answered? Are people like forthcoming, or what is your
I
experience?
come straight. Like if ever, if I, you can see their facial expression, and there's like, and then there's
Taken
some
back.
they're like, "Doc, I really been overdoing it. The past 6 months, I've been. Don't worry, I'm gonna stop." You can see that's kind. They kind of admit to it. Or some, do you drink every day? Yeah, but just one, one glass. Or do you drink then, do you drink every day? And then some are like, 8, 10 glasses of whatever it is, or, and and I'm like, you realize I'm doing this, you can't feel anything. And I'm looking at your labs and everything else is pretty much okay. And I said, you realize you cannot feel, you have no sensation, you're drinking your nerves away, you know? No,
Yeah.
I'm pretty I don't know, brazen about it. I don't hide. I don't sugarcoat that because that is crazy the fact that you can drink so much that you lose sensation in your feet. So
I know. I do. I know one time I asked a young man that, and I asked him, well, how much do you drink? Just trying to quantify the amount. And
Mhm.
so he said he drink beers. So I was thinking like one beer. And he was like, no, like a case. I mean like a six pack. I was like, a six pack every day? He was like, yeah.
I
Like
was like,
like that was
nothing.
not like
Oh, and then
that
I
was
guess to
not
add on to that, that'll
strange.
be gout. Gout is a huge thing here. Sorry, the
Yeah.
bear, gout is a huge thing. Besides that's huge. I see way more gout patients here than I did, where I was working prior.
Awesome. Okay, Dr. Mullah, tell us a little bit more about what you see.
So instead of alcohol, I'll go from the smoking side actually, because
Ah.
doing a vascular screening. So, and asking people how much they smoke, you get some people who are just straight out with it. They're like, before you even tell me, I've been smoking for 20 years. I'm going to continue smoking. I'm still here. It's not going to change. And then you get some people who they're like, they don't really want to say. And I'm like, how much do you smoke? Like, it's just me and you in the room. You can level with me. And they'll be like, okay, about 20 a day. And I'm like, 20 a day? Okay.
Where do
And
you
then
find time?
yeah, it's crazy. And then you start to see what's going on with their vascular. They're starting to say, okay, this toe is feeling a bit cold. I'm getting pains when I walk up the hill. I'm getting pains at night as well. The foot is looking a bit dark and a bit dusky. And I'm like, okay, well, maybe something's going on there. So a lot of smoking is going on, and especially, well, I don't know if it's something with medical marijuana, not medical marijuana, marijuana as well. People are trying to use it in a medicinal way, but they're not using it licensed as well. So sometimes you're mixing that with all sorts of stuff you don't even know. And what it's doing to your vessels, I don't think people really associate that with your feet also. People are thinking, oh, maybe my heart, my lungs, a smoker's cough. But people don't realize those small vessels in your feet, those are getting attacked. Some of the
Mhm.
other things we see, venous insufficiency as well. We're actually seeing a lot of that. And I read this paper that said what, up to, I think anywhere above 23 degrees Celsius, you're more at risk, your vessels, of getting some venous disease. And I think probably about 80% of my patients, I'm starting to see some starting signs of venous insufficiency. And when I started to tell them, okay, I mean, there's no point going for surgery just straight away. Let's try some compression, let's try some water, some exercise. And no one wants to wear compression in a hot country, right?
Oh, that's a big problem here.
Yeah, compression is a bad word in our clinic almost. People are like, not the compression. But it is something that we are seeing here as well. Some other things we see, a lot of plantar fasciitis, Achilles tendonitis as well. And I don't know about you guys in Bahamas, but we find a lot of people actually supinate. So for a lot of people who may not know what supination is instead of your feet just basically rolling inwards, they're rolling outwards. You're walking more on the outside of your feet. And we see so many supinators. And I've actually tried it myself. So I've worn Birkenstocks and some flip-flops and walked around the supermarket. And I asked my colleague who's with me to look at my feet. And you're going to start to actually walk more abducted and supinated. So just the footwear itself, and that's going to put pressure to your Achilles, a whole range of problems. So I actually think just changing footwear from that standpoint, you're actually going to change the biomechanics, which is just going to make a tremendous impact. I tell people a lot of the time, a lot of your foot problems are because of the shoes you wear. And people don't believe me. They think, oh, it's just bad luck. But I'm like, no, some of this could have been prevented. Oh, and one more thing I would say, which is which is more on my radar now, is well, cancers. So melanomas, subungual melanomas. and also actinic keratosis on the skin. So a
Mhm.
lot of patients, they're saying, okay, I've had this, it looks a bit strange. I think it's a wart. I think it's this. I scratch it, but it keeps coming back. I'm not sure. This nail, this dark line on my nail. And yes, sometimes you can get hyperpigmentation in nails, but there are some people who have sent to dermatology and they've come back positive. And
Right.
people are out in the sun, much more people are tanning, all that sort of stuff. So spreading the awareness, yeah, we're not just seeing diabetic patients, we're not just seeing corns, ingrowing toenails, that sort of stuff. Is even these things you have to think about as well.
Definitely, definitely. I see Dr. Horsley is here. Dr. Horsley, did you want to chime in a little bit? I was looking for you earlier. Did you want to chime in a little bit on that on the neuropathy? And then also I saw your comment in the chat about the drinking. So you can share that with us, please.
I didn't mean to crack you up. Hello, everyone. So good to hear everybody getting together on this great Zoom, and it's so informative. So, Dr. Knowles Adderley and Dr. Mullah, congratulate you starting out. And I know I tapped out of Nassau when Dr. Knowles Adderley was tapping in. So, um, that was about 3 years ago, and
Right.
congratulations on those young ones as well.
Thank you.
Yeah, so I just was wondering what, you're welcome. I was just wondering, how do you help folks like with diabetic neuropathy or polyneuropathy? Do you go with any standard medications or do you try supplements?
Um, First, I think my first line of treatment is always just the B complex, your B12, your B6. I try the supplements first, and we
Mhm.
try that out. And then the next step will be, your lyric or your gabapentin. That's more so it's not a treatment for it, it's just masking the symptoms, right?
You
Uh,
know,
so I explain that to patients that the treatment for it is let's try to get your try avoid so much blood, so much sugar circulating in your blood. Let's keep the diabetes down. That's the number one treatment. But that's in the next form, the next level of
so
treatment will be the gabapentin, the
avoid guava duff, huh?
gabapentin. Right, right.
At all
Exactly.
costs. That's a triple threat with the carbs, the extra sugar, and the
And
gooiness.
they're all about, they have all these commercials on the TV, so they all coming in. You don't have that thing to just shock it back. And I'm like, your A1C is 12. Like that's, let's start with that. It's not going to just get shocked back. But yeah,
But we're all suffering from the lack of early detection. And
right.
Yeah.
that's when they come in and their brain is fried. And it's very unfortunate by the time they have Charcot or the cube or anything like that. Normally, the brain is insulin resistant as well. The brain's not getting its glucose or ketones. Then the brain is mad and it sends you off to Krispy Kreme and off you go.
Mhm.
Yeah, that's something. Early detection. When the doctors indicate they're pre-diabetic, how nice would it be to have a early detection home test kit,
Agreed. Like,
5.07 MFW and 10 grams, and that can be done. Why would any nation in the Caribbean spend $100,000 to amputate, which is free? But to save it, it costs money, and
Mhm.
they save your limb. So that's kind of irony of it. But yeah, that's all. I just wanted to mention early. You both, all three of you, are absolutely correct about early detection.
mhm.
Uh, how about you, Dr. Mullah? Any early detection measures you're taking in Barbados?
Yeah, so we're doing pretty much standard diabetic foot screens. We're trying because we haven't got many podiatrists here. I think we do maybe have a bit more than Bahamas. We've got 11 now, but that's
Oh,
because
wow.
my colleague and I and someone else recently came back. So it was
11
eight,
today.
it just yeah, so it just went up to 11. But then you got people retiring as well, so it's a bit tricky. It's not going to stay at 11.
Right,
And we're
right.
trying to train some of the nurses as well, just to do some of it in the polyclinic. And even we were showing some patients as well. Yeah, a monofilament, how it works. A lot of people think it's a needle, but we're like, it's not going to stick you in your skin. It's just a touch. And we were even looking at the Ipswich touch tests and looking at the validity between monofilament and stuff. It's not as great as a monofilament, but we were like at least something to start getting people into the idea of actually testing for neuropathy. And in terms of treatments, yeah, I agree. The B complex, B vitamins, that's the start I always go to as well. In terms of gabapentin and sometimes amitriptyline, I don't really like to go there. And usually, if there's a pain specialist, I'd usually consult with them as well. But when I was in Sheffield, there was a professor of mine, and he was actually looking at an opsite film dressing to use on the top of the feet for painful neuropathy. And he was finding some success with that. He basically theorized it in that imagine a TV with lots of static. You put that on, and it gives the nerve something to focus on. And for some reason, when he was doing his studies, he was finding that it was working. Now, I haven't seen any recent or published research about it, but I did try it on a few patients over there and it worked. So I don't know. That's a field that, or an area which definitely needs some exploration.
Agreed.
Definitely, it's a big area for us as well that, so many people are suffering with that. And so I just want to recognize where persons are joining us from. We have someone from St. Thomas, Barbados, North Carolina. Of course, Dr. Hosley is from Detroit. Of course, New Providence, Grand Bahama, Long Island, and Wiltshire, UK as well. We have Eleuthera is in the house as well. Cat Island is in the house. So we just want to welcome all of you to our program tonight. And we're looking forward to the questions that you may have that are in the chat. And we're gonna just do our final question right now is we want to say, what do you envision for the future? And Dr. Mullah, I'm very pleased with that 11. That is fantastic. I mean, we would love to see that one day. When we have enough podiatrists to cover all of our islands as well as New Providence, that would be fantastic. And so, we have a bigger challenge than most other countries in the Caribbean do, in that we have an archipelago to deal with where we have, I think, 16 islands that are inhabited, that we have to provide all of these services on all those islands. And so it does present a challenge. And like Dr. Knowles saying, most of us, well, all of us currently reside in New Providence. And so hopefully in the future, we'll have that opportunity to, be on those islands and provide constant care, because we travel to the islands to provide care, but to have persons living there and, being a part of the health system there is our dream, is what we would like to see. So I see somebody from Atlanta, and I think I see Eleuthera as well. So we want to welcome all of you for wherever you're joining us from. So we're going to head now towards what is the future. Dr. Horsley, you can also think about this as well. We'll also like to hear you're at the other end of the spectrum. So Allysa, Dr. Knowles Adderley, and Dr. Mullah, I'm in the middle, I think, and they're at the beginning of their careers, and then you are heading toward the close of it. So we would like to just have a vision. This is an International Podiatry Day. So we would like to just have a vision of what we would like to see podiatry is in our region. How would we like to see this profession continue to grow? We've all been I was not in practice at the time when there were not licensure and prescriptive powers and all that stuff. When I came home, those things were already in place. But I think maybe 30 years ago, those were not in place. Okay, maybe even, yeah, probably 30 years ago for sure, they were not in place. And so we have seen great strides in the profession already. But what would we like to see for podiatry in the future? Let us hear what you're thinking. What are the future aspects or prospects you would like to see in the future?
So for me, well, first of all, thank you to all of the podiatrists who were here prior to me returning home, because it was a very smooth transition. I mean, it was a change just in general, just anywhere you move is going to be a change. But just to practice medicine here in the Bahamas, I was just a bit nervous on how that would look, what that would be like. And I just want to thank Dr. Mitchell, Dr. Johnson for just paving the way and putting things in place so that it would, people like me, when I return home, piece of cake, I just move on to just, treating patients, and I had no hiccups, no complications, and no setbacks. So thank you for that. But I'm actually very optimistic about where podiatry is going in our country. I believe we're on the cusp of a real shift. I think just both in awareness and in how healthcare is delivered. More people are recognizing that podiatric medicine plays a vital role in preventing amputations and improving mobility and supporting just long-term wellness. And that's we want to reach more of the population in general, but I think in the physicians, especially the physicians of now, the set that with Dr. Mullah and I think the physicians now, they understand more of the multidisciplinary approach. And I think that's going to be the key to the change we want to see or to continue to see. I think just everybody being on board there, your primary care physician, your endocrinologist, ortho, everybody just being a team, not just one set of doctors just trying to have everything for themselves, vascular, of course. But I'm seeing that. I feel like this generation and the one behind us, they're much more open to the collaboration and proper consultations. And there's a growing understanding that patient outcomes just improve when we work as a team, and podiatry being a part of that team. So I do feel very welcomed by the other professions that are maybe in my age group and below. And I'm very thankful for that. Like today I did a case this morning, and it was a team approach with me and ortho, you know, and that before that would have been a big deal, even in America, a big deal. But as I was even moving or growing in my profession prior to moving home, that uh I guess the fight between ortho and podiatry was, they were evening the playing field. And then coming back home, I just, just to have them to call on to say, hey, I need an assistant in this case, or they call me to assist in a case. Um, I think that's good. And I think we're on the right track with that. Um, my hope is that we'll continue to see greater integration within the hospital setting. I think we can get more consults and be consulted more and play a bigger role in the hospital setting here. Um, but I would also like to see just regional collaboration. I wasn't even aware that Barbados had so many podiatrists, and just, more interested to see who else is out there in the different Caribbean countries. Just to share expertise, training, and resources.
Awesome. Dr. Mullah?
Yeah, for me, multidisciplinary approach, I've been loving that so far. It was hard when I came back. Um, who I work with, Simone, she's put a lot of things in place, but she also told me, look, a lot of people are kind of standalone islands, and you're gonna have to build relationships. So I made it a business of mine of just trying to go out, just meet people, just shake a hand, say, hi, I do this, what do you do? Maybe we can work in collaboration. And even though we're not in a physical MDT hospital setting, at least having that kind of MDT where I know I can send you here, and keep everyone in the loop, that's big. And I would love that going forward, that podiatry is in the hospital as well, that is part of a care plan. You come in with a foot problem, you think podiatrist as well. And that would save, as in a preventative sense, save so many issues. So many things get admitted to accident and emergency, which I'm like, this could have been seen in a clinic. It didn't even to get to this stage, and we could even triage that much easier. So MDT, I think, is a big role. In terms of younger people getting in as well, I've had a few like college students and stuff shadow me, and they were like, this is interesting. And I'm like, yeah, it's not bad. You should look into it. And they're like, but you deal with feet all day. And I'm like, trust me, there are worse things you could deal with all day.
I say all the time, there are worse things.
They are worse things. But I think a lot of people are starting to break down those barriers. Okay, we actually do a lot more. It's not even just diabetes, it's peds, it's you do a bit dermatology. There's even forensic podiatry. So there are lots of different avenues, and really building it in the region as well. Some islands I know they don't even have a podiatrist. And I had someone who came, I think it was Belize, they came all the way over, and Dominica as well, all the way over just to see a podiatrist. And I'm like, you shouldn't have to fly hundreds of miles away just to see someone. I don't know if we can probably do little stints in the islands. I don't know, but definitely some regional approach. I'd love that. And hearing what you guys are doing in Bahamas, that's amazing. You guys do have a big task. When I look at Bahamas and all the islands, I'm like, how are you guys getting from island to island? We're only one island. We just have to drive, but you
Lots
guys
of
are doing
flights.
some amazing stuff.
Awesome. Yes, Dr. Horsey, did you want to chime in on this? No, you still on?
Thank you. Yes.
Okay,
I was muted. I had muted myself. And now,
no problem.
all right. But yeah, we all need to flip this script for sure. We all seem to agree. And one thing I found effective was the synthetic vitamin B1, benfotiamine, to help improve some of the markers on not only polyneuropathy, but long haul COVID, brain fog, and a few other things by getting that coenzyme ready. But for the first time in human history, life expectancy is on a decline. We are the sickest generation of all time, not just recent times, since the dawn of man. And most of the current treatments are just not working if the pandemic is getting worse. Flow to the toe and D-foot, and all of it is so beautiful, but the pandemic is raging on. People are getting sicker. And one thing we didn't mention that goes along with the diabetes is ED, erectile dysfunction. And we're talking just like Charcot is present in the early 30s, late 30s, so is ED. And that is a huge, huge problem. And finally, insurance coverage is decreased. They're cutting in healthcare. And so I can see the problem getting way worse before it even starts to trend to get better. But we have to save the children from this disastrous thing, like you said, Dr. Mitchell, with the obesity, lack of exercise, the diet. It's a lot of the bad oils, et cetera. It's a long story as far as that goes, but there's a lot. We have our work cut out for us. Can't hear you, Doc.
What do you see in terms of the future for podiatry?
It looks beautiful, but with only 11 schools in the entire world, and enrollment is currently on a decline in two podiatry schools, at least in America. I'm not sure about UK, but enrollment is, they're just meeting quotas in order to establish the class of 2026, for example. I think podiatry should be elevating and raising the bar, but for some reason or another, it's taken a big hit. It's like somebody put a hit on podiatry and it's suffering. Caught podiatry in the back alley, put some slugs in it. And podiatry, when I was in, was one of the top 3 professions on the planet. Now it's the 36th highest paying profession and falling. So a lot goes into it. You know, who wants to go into podiatry when you can work on Zoom at home and make 3 times as much just in your pajamas? So podiatry is extremely rewarding. I would never have traded it in for nothing, not enough rice in China to make me have traded in podiatry, and I think it's very, very beneficial. But something needs to be done, some hype, some promo, like your Zoom, and much more needs to happen to promote what's up with this amputation crisis, lower limb amputation crisis, and the type 2 diabetes crisis.
Awesome. So definitely, I agree with all of the recommendations or the visions that we have for the future. The collaboration, consultation, integration, getting the young people involved, and like Dr. Hussey said, the awareness, and getting just organizing and getting things moving in the right direction. I would like to also agree that, you know, one of the things, the vision I would have for our region is for us to have a podiatry school. We don't have a podiatry school in this region. You know, we have to all go to the United States or to the UK to be trained. And UWI, as our regional university, does not have podiatry there. So there's an opportunity for us somewhere in this region to begin a podiatry school and get persons in, because this is a region here. We have, I think, Trinidad, and a lot of us are some of the highest rates of diabetes in the world. And so we definitely know as the rates of diabetes go up, the complications also go up. And so we need to be prepared to deal with those things. So my vision would be to, in agreeing with all that has gone before, would be for us to have a podiatry school in our region. And it also gives us a better, by having persons trained in our countries, because we have a lot of persons who go to the United States and to the UK for training, but they never return home because the grass is greener in those pastures. So if we have persons who are trained in our region, we can tailor that training to what we see and what is important for us, so that, these persons would stay home and actually be a part of building our health systems in the region. So that would be my vision, for us to be able to train podiatrists here in our region, and to elevate them to be a part of the multidisciplinary team approach. And so I think that definitely from our discussion, we've had a rich discussion about podiatry and what all that we do and everything. And I'll just let Dr. Knowles come on and just tell us exactly where she works. So if persons need to get in touch with her, they will know where to get her, to find her. And I'd like to recognize this person on the iPhone that says, hi, they were from Eleuthera. We went down some time ago. I remember my good colleague, Monty Cambridge. Yes. Sadly, she passed away, but she was really, really a visionary in Gregorytown. And that was a wonderful opportunity to go there and do some screening and to see some persons there. Hopefully, we could do it again. But Dr. Knowles did mention that she is in Eleuthera, so I'm going to give her an opportunity to say exactly where she is. So in case you or other persons there would need to get care, they would know exactly where to go. So Dr. Knowles, you can tell us exactly where you are, and then Dr. Mullah will give you final opportunity to say final words as well.
I'll be in Eleuthera Tuesday. Tuesday's the 14th, right? I'll be in Eleuthera Tuesday. Roxtown, Eleuthera. I see patients out of the Family Medicine Center clinic in Roxtown, Eleuthera, and that's but every 4 to 6 weeks. So my next visit is on Tuesday, October 14th. I also see patients in Grand Bahama monthly, and I was just there last week, so my next visit will be the first week of November, and that's at Lucayan Family Care.
Family.
And then in New
Mhm.
Providence, you can find me at Oak Tree Medical Center, Family Medicine Center, as well as Doctor's Hospital. Either one, I have a clinic, and each one once a week. So you can find me at Tuesdays, Family Medicine Center, that's out west. Wednesdays, Oak Tree, and then Wednesday afternoons, Doctor's Hospital. Okay.
All right. She's very busy. So awesome. So I am at Family Foot Center, which is on Independence Highway. So you can find me there most days, Monday, Sunday to Friday, at Family Foot Center. On Tuesday, I'm at Bahamas Surgical Associate Center. And then I travel to Grand Bahama as well on a Thursday. I think it'll be next week, Thursday. I'll be in Grand Bahama at Lucayan Medical Center. So it's a lot of traveling for us, Dr. Mullah. Because of the nature of our country, we have to move up and down to provide the care that we need to provide to our persons. So you can look for us at any of those locations and make sure that we would be happy to assist with any foot complaints that you have. I see one question in the chat. I'm going to answer that before we go. So Charcot is a foot condition often seen in persons with high blood sugar or uncontrolled diabetes, where the bones in the feet are broken down or fragmented. So it's fractures, multiple fractures in the bones of the feet that cause that to happen. So the foot will break down and the shape of the foot will change, which increases the risk of ulcers and other complications from the diabetes. So it's a very, very complex condition. And if you know somebody who has it or somebody who maybe thinking they have it, they need to come in ASAP to be seen as soon as possible to get that foot checked. But we like to say all diabetics. If you know somebody who's diabetic, you love somebody who's diabetic, you even hate somebody who's diabetic, they should have their feet examined at least once per year. And based on what we find when we do that exam, they may have to come in more often, either monthly, quarterly, every 6 months, or even weekly sometimes if they have wounds. So Dr. Mullah, we're going to give you an opportunity to say last words, and then we're going to get ready to close.
So it was a pleasure being on here. Thank you so much, Dr. Mitchell, and everyone else who made this possible. I'm not in Bahamas, I'm in Barbados for all of you who want to know, and I'm at Comfy Foot Care Clinic. I'm mainly there most of the week. Other than that, sometimes I'm doing free clinics, sometimes I'm doing screening, going into the community, different things. But Comfy Foot Care Clinic in Belleville, call there, and then you'll be able to track me down. I won't be around
Awesome.
islands, it's one island. And what I would say to everyone as well, just general advice, feet matter. At the moment, there are no, I know of, there are no feet transplants. You get one pair for your life and you got to take care of those. And even as Dr. Horsey was saying for the guys out there as well, a lot of guys, they don't want to go to the doctor, the podiatrist. It's usually their wife dragging them. I'd say as a man, because I was like that until my mom drove me to the podiatrist. As a guy, we got to take better care of ourselves as well. And it's going to pass on through our generations, make ourselves better humans and a better country as well. So everyone keep up the good work as well. And thanks for having me.
Awesome. All right. Thank you very much, everyone, for being here. We are now going to have a closing prayer. I don't know if Elder Green is still on. If not, we're going to have Elder Mitchell, who's our pinch hitter. He's going to give us our closing prayer at this time. Thank you very much for being on the call tonight.
Let us pray. Father, thank you for this opportunity that we have had to educate ourselves about help that's available to us, help that we can use to make our lives better, to make our feet better, because as we were told, we only have one pair for life. Help us to do those things that will allow us to keep this pair for life in the best condition that they can be, to improve our quality of life, and help us to be an example for those around us. Help us to not just know this knowledge, but to share it so we can all have a better quality of life. Take care of ourselves and keep away from those things that so easily cause us challenges. As we leave this meeting, may we never be from under the umbrella of your protection and knowledge and information. In the name of Jesus, we pray. Amen.
Amen. Amen. Amen. Thank you all so much for coming. Wonderful. We have this meeting every month. The second Thursday of every month. The link and the log on is the same. Our next meeting is November 13th, which is the day before World Diabetes Day. So definitely we will be here with another exciting program and an informative program. So we are very, very happy that you are here. And listen up, and we'll be sending out the information, or just join us because the link is the same. So thank you so much. Good night, everybody. Thank you, Dr. Mullah. Awesome job, Dr. Knowles, Adderley,
Thank
and
you.
Dr. Mullah. Thank you all so much. We appreciate you.
Okay, good
Yes,
night.
Dr. Horsley, thank you as well, too.
Thank you, Dr. Mitchell. Good night, everybody.
Yes, good night, everyone.
Good night. Have a good weekend.
You too.